welcome everyone. My name is Emilia Andersson, and I work for Roche Diagnostics in the region Europe, Middle East, Africa, and Latin America. And I'm here with my colleague Anne. We are sponsors and really engaged in this wonderful initiative that CADQAS is doing for us of providing education and proficiency tests of various markers. So this time it's mismatch repair, MMR, that you have been reviewing, and we will look at the results. So with that, I would give the word over to Corrado and Simona. But before, just a final note. It is recorded, as you noticed. It will be published. And also, if you have questions, you're welcome to speak up, but also to add your questions in the chat, and we will make sure to address it. Thank you.
Indeed.
Perfect. Thank you very much. So welcome back. A couple of weeks ago, we had a little mini workshop for interpretation, and we spoke about mismatch repair in general using enzymes, so using immunohistochemistry or other ways. And we had 6 cases, which I thought were relatively straightforward, but there are always some things to discuss. But then also, do I press this one?
Perfect.
No, I don't press this one. Sorry, I'm
fine.
tentative. I need to pin this first. Yeah.
Lovely.
And then press this one, and then we'll have some cases, also some other cases, just to discuss with you. We take some photographs. We promised.
We promised last time.
Okay. So first case, I don't think there was any controversial. It looks like everybody thought this was all the markers were expressed and microsatellite stable. Only I promised you we did some additional tests. So as you know, the immunohistochemistry looks for expression of these 4 enzymes, which are involved in the detection and repair of mismatch. But also there are other ways of doing it. So the old way was to detect the noise in the microsatellite regions. Let me see if I can go to page 2 here. And this is a typical printout from one of those machines where you press the button and you don't know ever what happens. So this is what it is. Originally there were the 5 Bethesda markers, and then there were the new Bethesda markers, CL5. But now manufacturers have devised other markers, so other regions in the DNA that are prone to errors in copying and provide noise, and these are proprietary. They become proprietary to the systems. In this particular case, 2, 4, 6, 7, and 0 means we didn't see any noise, and 1 means we found a lot of noise. And so in this case, you would probably have to report this as microsatellite stable, because you are looking at microsatellite instability, and therefore this is associated with proficient mismatch repair. You agree?
Indeed.
Yeah. I don't think we need to see the slides.
We need to see the slides.
We need to see the slides. Okay.
We've been through a little bit of the comments. It's 8.
Number 8. Okay, you've seen the comments, so you tell me. I can't see anything here. H&E.
We can start in order, I think.
Okay. H&E, okay, so these were, as usual, endoscopic biopsies. It's invasive carcinoma. This one, I don't think so. And this one is probably invasive as well here. There may be another bit. Okay, it doesn't matter. Okay, so that's the tissue. So first marker here is MLH1. Okay, everything looks brown. This is a germinal center, obviously. As you can see, actually, the tumor is different. The nuclei are bigger. This is very tidy. This is a gland, a native gland, and this is tumor. And also it's darker.
Indeed.
Yeah.
Indeed.
So potentially we should find some cells that don't stain, and there are these endothelial cells that don't stain. This one, I'm not entirely sure this is specific. This looks like dust, like staining chromatin or polymorphs. Who knows what is happening, cytoplasmic. Okay, I'm sure there will be better areas. Yeah. Okay.
Then after every single case, we're going to go through the comments a little bit, because as you know, we also ask you how you would report these.
Okay.
and the comments
So
made.
this one would be preserved, and because
Yes.
it's preserved, they should function. And then we go to the next marker,
think
which
we can do
is
MSH2.
no, I want the pair.
PMS.
PMS.
Let's
find PMS. Okay,
last
here
one.
is PMS.
Good.
Okay, again, this is a bit backgroundy again. So kind of, but you still find cells that don't stain.
Yes, exactly.
And all of this is probably a bit of rubbish, to be honest with you. Not so well defined, but you can see the tumor is staining. There was another piece of tumor here.
And I think in this case, some of the questions were indeed indicating this PMS2 staining. There were a little bit, a couple I think were calling indeterminate.
Yeah.
Which
a bit overwhelming, but again here, okay, the staining is not fantastic, fabulous, but here you see the normal gland that is slowly losing it as you go to the surface, which is in keeping with the fact that it's going to rest when it's on the surface. The proliferation fraction is down below. Kind of, I would say, this is okay, this is proficient, and then the other two pairs.
So you have the nuclear that were really positive. Indeed, you also had some cytoplasmic flush and some dirt over there, so-called, but...
Okay, so I don't know how much of this is specific or non-specific in the cytoplasm. Potentially proteins are produced in the cytoplasm and then transport to the nucleus, so you may get some signal there. So this is MSH6, and again, I think is okay. So some of these markers work better to the eyes.
MSH6, from my point of view, is one of the... If MSH6 didn't work well, I'm not expecting the other markers to work well.
Okay. And
so
again,
it's my reference
And again,
point.
You see this gradient, which this is where you should be. I have to say that often we find more stromal cells not staining here. There's a heavy lymphocytic infiltrate and they're not staining, but here you see some of the spindle cells are not staining. Okay, so this is preserved, and then the last marker is MSH2. And again, the tumor can be identified. I mean, when do we stop believing our eyes and saying, oh, this is a non-specific staining? And I think maybe each pathologist has his own threshold, I guess. So I don't know what were the comments. Were they related to the fact that this
it is a little bit overstaining, yes. Yeah. Some people were saying it is overstained.
You can still find negative nuclei, but I agree, this is a bit heavy.
And again, the comments about PMS too.
Okay.
Can we though look a little bit of the comments, because I think here, and I've seen also of another case that was a comment like this, and I would have liked to make here. Controls does not show decrease in staining towards the top of the crypts. I want to say they do, not in all of them. But unfortunately, nothing is perfect. So we need to work with what we have.
Yeah. So I think, these slides come from the routine. And, routine, sometimes it is what it is, and you need to try and make the most of it. I try to show that even in the test tissue, you could see that there is a gradient.
Yes, exactly.
That's helpful.
If you don't have anywhere, then yes, I would. Yeah. This comment, MMR, the status negative. I would advise to not go for double negation, deficient and negative. Just go with mismatch repair proficient.
So, yeah.
It's better for the clinicians, I think. It's better for someone that is very quickly reading the report and not paying that much attention, which they should pay attention, but
sometimes they don't. So they see D, they say, oh, this is deficient.
Yes.
And then they don't take care of the negative.
Exactly.
I have to say that sometimes we get some referral cases, and there is this huge, usually breast pro forma, where there are all these lines. And of course, when you write the pro forma, all the lines are in separate lines, and everything is lined up and everything makes sense. And then you put it in the lip system, and then you do a printout, and then it forgets about space. Everything is one after the other. And so you read, and you start reading DCIS, and you think, oh, there is DCIS. Yes. And then maybe in the next line you say absent. But if you don't, maybe if it's even in the next page. So it gives the false impression. I hate these type of things, So please don't talk to me about DCIS if there isn't.
If there isn't, yes.
So I think it's a good suggestion, let's call it proficient,
exactly,
rather than call it deficient, absent.
And maybe, as mentioned in the brackets, retain expression MMR proteins, indeed, and like any other comments mentioned here, with the that Lynch syndrome is probably absent, or there is a very low expectation to have. And
what about this comment? These were the kind of reports that you write. No loss of nuclear expression MMR protein, good. Low probability of microsatellite instability.
And there are many like this, but I do think this is how the guidelines are saying that you should report.
Also, they're doing it correctly.
So I think that because there are low probability of MSH high, then another one, low probability of MSH high, then low probability of microsatellite instability.
Okay.
I do think we should be a little bit more, is not, because we are interpreting on immunohistochemistry, and all that we can say here is mismatch repair proficient.
So I think this is a broader question. I said, as you know, I always say the guidelines catch up with you. It's not the other way. You don't look at the guidelines for guidance in the future. It's firming up what has been done in the past. But usually, by the time our colleges or whoever it is, the right guidelines catches up with us, we are 2 steps ahead again. So I think this microsatellite, as we spoke about in the workshop, these microsatellites were surrogate markers of the fact that the DNA mismatch repair system in those cells do not work. And because these microsatellite regions are highly unstable and very easy to copy mistakes, if you don't have things that correct it, you're going to accumulate a lot of noise there. And that's microsatellite high. But I think this is a thing of the past. And I do know, and I remember that even some current guidance for drug availability talks about MSI, still.
Yes, exactly.
But I think this, we are pathologists. We should be more precise, more scientific in this.
We did make a comment of our previous on the theoretical part of this, exactly.
Okay.
And the same thing of, I lost it, I think.
But
now
in the previous
no, wasn't just a second, was here something again with no loss of something. I don't know. That doesn't matter. No evidence of deficient mismatch repair. I think it's no evidence of deficient because it's proficient.
Because it's,
So I would just, our advice and what we noticed, and from our collaboration with the clinical part and everything, that they really like a very clear conclusion saying mismatch repair proficient or deficient and things like this.
Okay, so
and we discussed about PMS2 that was a little bit.
So here there is a beginning of a comment that it says it's preserved in less than 10% of cells. Preserves nuclear staining in less than 10%. So there is a beginning of something about quantification, and I think we want to show you some cases where I think we also have some cases in the circulation where there are some issues about heterogeneity.
And this common mismatch repair proficient favors sporadic Lynch syndrome.
Okay, on the basis of what?
I don't know. I wouldn't go into the Lynch syndrome. If you are proficient, can you imagine even if a patient that doesn't have any knowledge of pathology or more medical stuff to read favors sporadic Lynch syndrome, and he starts Googling Lynch syndrome and so on. What do you mean favors sporadic Lynch syndrome?
Okay, so let's concentrate on these 2 sentences here. The first one is suggestive of microsatellite stability. Okay, we spoke about that, but it says low probability of Lynch syndrome. So in reality, Lynch syndrome, you're right that some cases of Lynch. So you're right in that even in patients with Lynch syndrome, you can get tumors that do not arise in that context. So the normal pathways are activated, But in general, it is considered that if you find proficiency, you don't really talk about syndromic cases, So it depends, if this is a patient that has microsatellite instability as a congenital background, and then you find a colorectal cancer with a preservation of then you do make a comment, but in this case. And then the next business about favor sporadic Lynch syndrome. There isn't a sporadic Lynch syndrome. Is that a Lynch syndrome or is a sporadic case? So there's a bit of confusion here.
We just need to be a little bit more careful of how we are phrasing certain things.
Emilia will keep an eye, because actually by definition there are lots and lots of comments here. By definition, we're not going to read all of them, but Emilia will keep an eye on whether the chat reminds us that we forgot to talk about something important.
Okay.
We move on to the next one.
I think we'll go faster.
Next one.
In the chat, we had this question: what context does the background have?
The background tumor, normal mucosa.
I assume it is the normal mucosa.
The normal mucosa, actually, the context is not very relevant because the normal mucosa, even in patients who have who are syndromic, they will have functional allele. So normally they will express the molecules. It's only the tumor that loses the other allele, the functional allele, and it doesn't have a reserve because the other allele is mutated.
It's sometimes good as an internal control, but you still have the stromal cells which can guide you more.
Yeah. Okay. So next case looks like this. It looks like
it could be straightforward.
No, do you think we need to look at the slides?
You know what I will do before? I will have a look at the comments before to see if we need to insist on
comment
overstained. Okay. Background staining control. Okay. Then PMS2 control is weak. Internal good. Yes, it happens. Okay. These are all people are okay.
I think we're happy with
and
this.
The next page.
It's another page.
We have many comments. And I think this, So I think this is like everyone was happy with an MMR proficiency.
Fantastic. And I can show you that
EDILA
again, all the 7 markers show no instability in these things.
So okay, fantastic.
So that's reassuring. It's just another way of looking at things. We just did it as an exercise. This is third case. So here there is sounds as if there is a problem with MLH1 and PMS2. While the other ones are preserved. A few were not very happy, and the
EDILA was concordant with the assessment.
Yes. So this is the EDILA result. Again, you can see that there are bits that are.
So you have 6 out of 7.
6 out, so 1.99, 1.11, and this. And 0.8, and this one is so usually you need 2, I think,
I think
two of these markers to be considered microsatellite unstable. Okay, so the case would be, you remember?
I think it's 10, the last one here.
Okay, so that's a large case.
Okay.
Well, that's very nice, and there is a little bit of normal mucosa at either side. And maybe we don't even need to open.
Well, I can see the PMS2. Sorry, it's quite.
It's gone.
Bluish. So.
Okay. So again, it's nice to have those normal mucosa. This is a much better stain slide, I would say. You see the gradient and goes up, and then the surface is gone. And in fact, we could be lucky and appreciate the gradual loss. You see the cells become paler and paler. And then, of course, this is the tumor. The infiltrate is still positive. It's a much better stain slide. You see the granulocytes don't stain. There isn't that granular dirty background, which some people say this is not acceptable. I want to repeat it. If you have that granular background and the endothelial cells are clean, etc., etc., endothelial cells are usually resting, so they would have no business to have this repair mechanism activated. Okay, so this is deficient, definitely. But the other ones, MLH1. What happens to this one? It looks the same, doesn't it?
Yeah.
So loss.
A little bit. See, even in the tumor cells, you have a little bit very weak staining, some of the tumor cells. But in big contrast with the stromal cells, that this is our internal control and also the normal mucosa. I would say, especially on excisions, be aware of pre-analytics, be aware of fixation, be aware of all of these things, because those are very tricky when part of the tumor stains, part of the tumor doesn't stain.
So I would like to make one comment. One comment is that this staining, that some of it is not actually even nuclear. This is the kind of staining that sometimes we used to argue with ER and maybe with Ki-67.
Yes.
That is not real, you know, and some of us say, oh, it's not real. The other thing is that, interestingly, I don't think that the 100% of the population of a tumor will be completely the same. Some of these things could be immune cells, and some of these things could be dead cells, because look, dead cells will stain.
Yes.
If you're a dead cell, you will pick up staining, and it doesn't mean that it's real.
Well, it's the same thing with the macrophages, that when they are eating other things, and melanoma, when they are eating the cells, and then they are
coming up with melanoma or
exactly,
something. But okay, so this one is a population assessment, I would say, but in general, I think it's all negative. Yeah. Okay, and then the other two markers, how do they behave? Let's see.
I think they were a little bit of indeterminate, right? 5% something. MSH2 and MSH6.
Okay, this one, we struggle with this one.
Because it's a little bit whooshy-whoosh.
Yeah.
That's why. Okay. It's not that strong that we would like. It's more like moderate, but compared to the internal control, which it's the strong is the same strong.
This looks to me like a slide that didn't see a lot of counter staining. You see, so there is also a bit of an issue with the blue. Okay, but again, in the context, you are trying to understand whether there is immunoreactivity. And I think there is in the tumor overall. Okay, and then the pair would be the 6.
Which is a little bit better.
A little bit better. And again, here your contrast with the surface. Some of it is missing.
Yeah.
Yeah.
But here I would raise the question, is it a matter of pre-analytics? I do not know.
But tell me something, why for one marker the pre-analytic doesn't matter and the other marker the pre-analytic matters?
Maybe one is more sensitive than the other one, is more sensitive to this.
Different antibodies, different epitopes, etc. And but again, the ballpark relationship here is positive.
On the other hand, we already are calling this deficient because you have the other two.
Yes. And who knows, one day it may be really important to understand exactly what all the markers do. But at the moment, it's just mismatch proficiency or deficient. Okay, so do we have
look at the comments here?
Comments?
Weak MSH to MSH6.
Yes.
I would say more MSH2 than 6, but yes, MSH2 unacceptable. No control, no counterstand.
Yeah. I mean, again, here you had the possibility or the opportunity to assess the whole case, you know, and then you need to tell me, Corrado, this case, I cannot report this case. Or in the context of all I see, I think I can report it. I would say, I think I can report it.
Yes, because I do believe you can, especially because on the considering the MLH1 and PMS2 are already deficient, and I think we are quite strong on the basis that they are deficient. So now even if MSH2 is unacceptable or it needs repeating, yes, we can repeat, but...
Okay, so here is the usual story. Please do a BRAF mutation testing for triaging it to syndromic, non-syndromic, and also because that provides an additional prognostic point, as we discussed a couple of weeks ago. Deficient internal control working. Okay, so that's good. Next.
The loss of MLH2 and PMS2, the same. MLH6 presents heterogeneous expression. I did not write.
Which one?
MSH6. Was it MSH6 where you said there are areas? Yes, you said there are areas that do not stain.
Yes.
Okay.
What does it mean? We don't know. But we are.
Okay. We agree with this. Yeah.
It's interesting because on one side, on one hand, I mean, I'm encouraging you to be more scientific and more precise as a pathologist and calling things mismatch repair deficient and not microsatellite instability, etc., etc. On the other hand, I'm going to tell you we can't dwell on every case. Any diagnostic case, you need to provide a diagnosis and move on because we have a lot of work to do.
That's true.
And there are other patients to be seen. So, yeah, it's a bit of a of tension there between these approaches.
Let's see the next one.
Okay, there is more.
Yeah.
More comments.
We really appreciate your comments. Really
Methylation for promoter, absolutely. Because as you know, this is a very good point, this business here, because as you know, they could be silencing. So the gene could be all right, but the promoter is methylated and silenced, and therefore you would have the same effect. And to be honest with you, most of the colorectal cancer with MLH1 loss is due to silencing. So the Lynch syndrome patients are smaller numbers.
I would say here probably was meant PMS2, not MSH2 lost, but probably.
Yeah.
Suggestive, deficient, so people were happy. No background staining, summary and PMS2 focal reaction. Indeed, we talked about this. Lovely. Someone even graded grade 3 adenocarcinoma. Lovely.
Very good.
Yeah. Okay.
Okay, fourth case. Again, here seems to be no problems. Yeah.
No problems, but it was a little bit of problem I can see between the panel diagnosis.
Oh.
With the MLH1 and PMS2. So we need to figure it out with MLH1 and PMS2.
Okay, so
you go, because I have no idea where it is.
It's here.
Okay.
Case number 9.
More up, that down.
This one. Okay, that's the H&E. Endoscopy biopsy, probably tumor, tumor.
Yeah, you have tumor.
Probably, yeah, tumor. There's tumor everywhere, more or less. So maybe not here, but okay.
Yeah.
Cool.
So it was between MLH1 and PMS2.
MLH1 looks promising.
Yeah.
It's here. And it's here.
Yeah.
And it's here. It seems to be preserved. So you will see in other cases where we really should look at all of the tissue on the sections, because there may be surprises. I think this is poorly preserved.
Yes, and crushed.
So one is good. This one is
two.
Sorry, I need to find PMS. Last one. Oh, they're alphabetical. That's why I was thinking. Here, less definite, but probably they're a bit heterogeneous here.
I would avoid that one in particular. You can see how crushed it is, and the staining
seems to be there. Could be more enthusiastic. No?
Yeah, it could be. It really could be.
Could be more enthusiastic, but in general, is there? Yes, you see here there are some that are not staining.
But look how tractioned it is, everything.
You mean squashed?
Yes.
Yeah.
And you have some also, the stromal cells are a little bit, again, weak, but I think they are there.
Yeah. Okay. So we would say proficient on these two.
I would, yeah.
And then 2.
MSH2.
I think this is also all good. Quite
this
nice.
Is better, yes.
Yeah. And then 6. Okay. So there is maybe some people thought was a bit of a wobble on the expression of
the first two, MLH1 and PMS2, although the people call it, I mean, the participants called it proficient.
Okay. Okay, so let's see what the IDILA showed. Yeah. Where is IDILA? Next one. IDILA showed stable. No satellite instability in these markers. Okay. Some comments.
Conserved. Look here, this one. There is loss of MSH to MSH in some tumors.
So is preserving your cell. I agree.
Fair enough comment. Yes.
Yeah. Fantastic. And then next.
But maybe, Corrado, maybe you could just comment on this focal loss. So how much focal is considered focal loss, and therefore also?
So there are two things that are a little bit odd about this focal loss. PMS2, not really a highly lost in general. And then the whole slide didn't seem to stain very well. There seems to be a decrease in immunohistochemistry performance throughout. So PMS2.
Yes.
Which does not encourage me to start making a lot of conclusions out of these things. You see, look at these stromal cells and immune cells and compare it to, I don't know, another one randomly opened. You see.
But this I feel is on the opposite spectrum.
This is on the opposite spectrum. So let's open another one here.
MSH6, yeah.
But if you see what I mean is that, look, there should be staining in immune cells in most of the time, and so Emilia, I thought the PMS2 for some reason wasn't really the most brilliant example of good staining, but probably sufficient to. Okay, so that's now. What would we do if we need to investigate this? And I mean, I showed you the edilla. So the edilla is essentially you take curls of this tissue and you put it into a drawer and you press a button. So this will be a population study. And if he's only going to tell you if it's above a certain amount.
Exactly.
If there is instability below a certain percentage, he will not tell us. You can do NGS, so you could sequence. And again, it will tell you that there is a mutation only if it's above the threshold you gave, 5% or whatever you want to use it. So, I don't see, unless you do single cell microdissection in this particular case, and you start studying what the individual nuclei are about. And then, Emilia, I don't know whether there is any clinical reasons to try to dissect each case like that. Do you know of any?
No, not really. I just, thinking about if you have a case where you don't have the beautiful, most beautiful staining, and you see some areas and you're in that situation, is this a focal loss or is it just a poor area?
We would like to show you some cases we photograph at the end of this presentation, because I think it's an important discussion we should have. Let's quickly run through the rest of the cases, because we're almost there. This one is easy. Do we need
Let's see the comments. Because if there are some.
So this is the DILA.
So
consistent with the immune. I'm not telling you that you should do both tests. I'm just giving you these other tests for this particular exercise, just to give you some comparative parameters for this. So these are the comment, poor immunostaining, bleaching also. I don't know about bleaching. No sign of microcytoma.
Should we look at PMS2? Because I can see mainly there we control.
PMS2 is an issue.
Now I forgot to see which one was it.
Just a moment, I will go back here.
24.
24 would be this one.
Yeah, that one.
H&E.
H&E.
Looks
before PMS2, let's look at MSH6, because I trust my MSH6. That's my favorite.
We could cut sections a little bit better sometime. Okay.
In the laboratory defense, sometimes we are receiving just
I see. This was somebody else's mistake.
So saying we do not know if receipt blocked and we cut it off there were slides.
Which one do you want to look at?
MSH6 first one, because I would like to see a nice staining, what we expect. Perhaps.
Okay. It could be overstaining. What do we know?
If you want to see an overstaining, look at the MLH1.
Okay, this is MLH1.
Oh, I don't know. I'm just saying. A little bit.
Too much. Yes, I agree.
Again, this is something every laboratory is different. And
then what do you want me to
PMS2, because that was the
question.
Yes.
PMS2. Okay.
Yes, it is weaker.
It feels as if people forgot to put the enhancer or something. It lacks bite, no?
Yes, a little bit. Yes.
And then it's a bit unfocused.
We agree with you.
We agree.
Yeah. But again, these are daily cases that we are receiving and we are reporting, and I bet you also have these kind of cases, and sometimes we do struggle with them. And this is, again, a little bit overstained.
But I have to say that each antibody performs differently.
Yes. And at some point when you have batches, you can see if you are calling something proficient, you will know how to call the other ones, and especially with this PMS2, PMS2. If you had more cases around that time and they all look the same, then you are kind of getting used, you're staying so-called, and you're getting used with it.
But you think this is
I agree, it is
good approach, is a scientific approach?
No, I think we should try to improve and to do better.
Because Simona, I still remember it's burnt into my forehead here, frontal cortex, a case where one of my colleagues decided that the diagnosis was the diagnosis, and he showed me an S100, and the S100 was black from one side to the next, but black was everything was staining.
Oh, yes. Well, then.
And the argument was, yes, I know that there is background staining, but my cells are staining for S100, therefore it confirms the diagnosis.
If everything stains, that's why, if you are taking this PMS2, the stromal cells are way much weaker, but you still have that patchy, the wild type with different intensities. However, unfortunately, the most strong intensity, we do not have it there. That's more weak and mainly moderate.
Okay, but my comment was more towards the side that you are starting to get really used to compromise, and then you compromise more, and then you compromise more, and then eventually you find yourself in an area where people look at you and say, well, how did you even get here?
Agreed. No.
We have a few comments now. First, one question that the PMS2 is always weaker than other stains in this person's lab. And the question is this something observed in other labs as well? So maybe this is a question to all participants.
Well, yes, who knows?
You can use your thumbs up or thumbs down. Thumbs up for observing the same thing, and thumbs down for not observing that.
Well, I can, if you'd like me to start answering to this, I can say that can you hear me?
Yeah.
We communicated with other labs and they seem to have the same issue, plus sometimes background staining. And some of them use different protocols for the excision and the biopsy specimen. So they try to kind of adjust, especially to pore fixation as well.
It will be interesting if, like Emilia said, if the people that are participating now, if they could react to this.
Yeah,
So
I guess there should be data in UK NIQUAS or Nordic QC circulation, but somehow I fear that we are all very mindful of not failing UK NIQUAS circulations. So we will do whatever modification of protocol is required in order to
match their controls.
What do you think? Yeah.
And another comment, like related to MSH6, I don't know if you touched upon it because I done other things at the same time, sorry. But sometimes with the biopsies is straightforward and easy because it's pre-treatment, but it's worth mentioning that about 20% of neoadjuvant treated colorectal carcinoma has decreased or even complete loss of MSH6 without it being microsatellite unstable. So
that's a good point. Yeah.
And why is this? Does this happen?
So the thing is, I was trying to find some information on that. If anyone has any insights, because there are studies showing that this happens, and if they went back and tested the biopsy, it was expressed. So it's an issue with expression of MSH6, but I don't find any insights on the mechanism of.
Well, I know that Richard is online. Our friend Richard, he may know something about it.
Yeah, if anyone knows, please. I'm curious.
Okay, so any other comments in this page? I don't think so.
I think it was mainly about the
last case, and then we look at some interesting. Oh, this is a bit more noisy.
Yes.
Yeah.
Okay, so people were happy with MLH1 and PMS2, not happy with MSH2 and MSH6.
Okay, so this case 25.
Yeah.
25. Here it is.
Okay.
Don't know.
Yeah.
Up here. Yeah. Okay. And then here, maybe,
More.
maybe not.
But can you zoom in here a little bit? Even the H needs a little bit. Okay. I thought it's more pre-analytics, but
not,
that's a normal. And then again here.
Maybe here. Okay. And then what happens here? Well, this is a gastroesophageal junction, maybe. Who knows? Or anorectal. Who knows? Okay. Which one do we need to look at?
The other two MS. Let's start with MLH1, PMS2.
Okay.
But this one, I think people were happy with it.
Preserved.
Okay.
And preserved. PMS. Kind of preserved, and there's an area here that is not performing very well. That's the normal kind. Okay, yeah. It needs I don't know. It needs some Viagra, ecstasy.
Definitely. Let's look at MSH2.
Oh, sorry, I opened the wrong one. MSH2.
Yeah.
MSH2.
Let the MSH2 look. Hold on. Well, go.
Oh, well spotted. And what's happening here?
I don't know. Zoom out. But then why is this?
Okay.
Okay. Let's look at this. Was normal here. Yeah. Okay.
So this is loss.
Yeah.
Huh. Okay.
So I'll be happy to call it loss. Yeah.
And this is also loss.
MSH2.
So do you think that we saw some expression in this gland, because in fact this was not invasive here?
You know, I remember when I was a trainee, and especially on the excisions, that it was even more easy. Not on the, we weren't that on that time, although I'm not that old, we weren't performing on the endoscopic biopsies, MMR. We were doing it on excision specimens all the time. And my mentor back then was always telling me, MMR, it's a diagnosis that you don't need to put the slide under the microscope. You can just look at the slides with the naked eye and you can tell it.
Yeah.
Ideally, exactly.
It's like lymphoreticular pathology.
Yes.
Yes.
But yes, this
So
kind
I would
of cases,
say, say there is loss of 6 and 2, or at least. So this one, it would be interesting to know what the microsatellite instability showed.
And can we just with the question, because since this the comment here is that the case presents areas of tumor cells that do have immune reaction for MSH2 and MSH6. So what percentage, or is it the percentage that you're looking for, or is it just identifying a focal loss?
Yes. Is it, or is it focal loss?
That's a good question.
It's a good question, but interestingly here there is no signal.
Yeah.
No, so this is stable.
Yeah, and I think on this case, Adelina will want to make some comments that I think this case was also sent to NGS.
And
I think.
And what did we get?
I think was like the IDILA stable. And we sent everything that we had. If she wants to unmute herself and give more information, but as far as I know from her.
Hi.
Hi.
Can you hear me?
Yep.
Yeah, so with these cases, this is, to me, is very problematic because first of all, we have the question, what is doing what? I mean, the dysplasia is proficient or the invasive is deficient. What are we looking at? So in these cases, well, the recommendation is, especially in colorectal carcinoma, is to interpret the immunohistochemistry and base our judgment on immunohistochemistry. So what I've done is I said it probably has heterogeneity of MMR, and it better be repeated on the excision specimen.
Yeah, good point.
So I discussed this with the colorectal pathologist from Memorial, who said that she never performs NGS on a colorectal carcinoma that is has a certain pattern. So the thing is here, you don't have So the deficient areas are clearly demarcated from the proficient areas. It's not as if it's mosaic and you have cells, mixed cells. So we really do need to give credit to immunohistochemistry. So she said she had cases in consultation that were sent that had a clearly deficient area, and then the rest of it was proficient, and people would do NGS on it, and then they were all microsatellite stable. And then she said no, because we need to base our judgment on, I don't know what you think, Corrado, if we didn't have any signal, but we need to look that, we need to kind of understand the proportion of the cells that are on immunohistochemistry MMR deficient, because we have lots of immune cells, we have normal mucosa, we have, I remember on this case, because I discussed with Ali and Sarah that we only had a few sections, so we put all the tissue through when we performed this test. So I don't know.
Adelina, can I just ask, did you consider like dissection, macro dissection or macro dissection, or only sending the deficient area for?
So it should be very precise, because we had all those lymphoid aggregates around the deficient, especially the deficient area is much more, is rich in this lymphoid infiltrate.
But guys, just to give you an understanding, this is 1.5 millimeters in diameter. With our coarse way of dissection, macro dissection, this is...
It's not really
It needs to be micro,
cell level dissection.
Yeah, we need a laser capture microscope.
And Adelina, could you clarify again, because you have a question here, is it the dysplasia or is it the invasive component that you consider deficient in this case?
So I think if we look at that fragment that Corrado was...
The very first one, yeah?
Yeah, I thought the more complex areas, no, the one you were looking at previously, they look like those were deficient, but I wasn't very sure. So I said, you know...
I think the right approach, like Ada said, we should repeat it on excision.
Certainly repeat on excision. Certainly repeat on excision. Also, you see, this is, I think, a fantastic case to show how those grind and test techniques have limitations, and they may not give you the right answers. And unfortunately, it would be good to understand whether eventually these patients would benefit or not, because patients such as this with microsatellite instability would be eligible for second-line immuno-oncology, which otherwise they wouldn't get in colorectal cancer settings. So it would be interesting to see whether they do have any response to this treatment. So in this context, I wanted to show you a few more cases that I have photographed after all of this. So this is one case, that's the H&E. Actually, maybe we should put is as
slide.
What do you call it? This one?
No,
this one. Fantastico. And then get the pointer. Okay, so this is the biopsy, and there are two areas, one here, which I...
Can we say that this is a gastric biopsy?
We could say that.
For people to be aware that...
A carcinoma looking like this in this area, and a carcinoma looking like this in this area. And then this is the top area. And this is the immunoprofile. I would say nice PMS2 and MLH1, MSH2 and MSH6 weak, but probably expressed. This is the bottom area. And you see here on the right-hand side, loss of MLH1 and PMS2. So kind of mosaicism. And this is the grind. The grind says nothing. Yeah, I can't find evidence of microsatellite, but this patient, if you reported, this patient may have access to immuno-oncology rather than not. Another case, how are we doing for time, by the way?
I think we still have 10 minutes.
Very good. There's another case, and these two fragments, invasive carcinoma here. First area. Oops.
No, it's not with the first area. It's the same area.
Same area.
Yeah.
Yes. So here you have loss of MSH6 only, and you can say the other marker. And this is another area. It's the same.
Yes. That way.
And do we have Idilla?
Yes.
So we have one 2, 3, 4, 5 loci at which there is instability. So this would be high with okay, so sorry, this was not mosaicism. This is just an example, nice example of MSH2 loss, MSH6 preservation. How does this happen?
I think you put it the other way around. So the loss was only MSH6. Only the previous one, you had it correctly.
Okay, we won the previous one.
Yes. So only MSH6. And
So
this
why?
is very interesting, exactly like you said on the theory part, where there are more partners.
Yes, because MSH2 has MSH3 as a partner
as well.
But so it could survive because they only survive ubiquination and degradation when they are complexed with the other the part. Okay, so that's a nice case, whatever that means. But this was not what we wanted.
And we need to show this by the slides.
Sorry, by the slides.
This DMSH6 with this last case, we weren't sure if because usually this one 00443. We do not have only one marker. It can happen, like Corrado was saying 2 weeks ago, because they have multiple partners, but it's more rare. And when you see like this, or at least when I've seen only the MSH6, which was very promising, I got a little bit, is this for real? So then we performed EDILA, and it was MSH high with
I have to say we haven't had the ability to do microsatellite instability studies for a long time.
Yes,
it's been relatively recent. And I find this a reassuring area, and we use it sometime where we feel, yes, the antibody may be staining, but I'm not so sure. Or there is heterogeneity. Do you remember those cases where there were intragland heterogeneity?
Yes.
Is there something, let's get another way of looking at things. Okay, so this case, tell me about this case.
This case, we received it for mismatch repair. To do it, it became as invasive adenocarcinoma, no other things. It was an esophageal. That's it, invasive adenocarcinoma. Beautiful. You can see some tubules here, some glandular.
But yes.
Well, yeah. And a little bit more here, a little bit more here. Although this is more interesting because here it's more not diffuse, but more poorly differentiated, I would say. And with necrosis here a little bit. And anyway, that was the HNE. Well, we performed a little bit more. Unfortunately, time was a little bit to take proper pictures. And then I made a little bit of annotations because this area and this area here, where we have with the tubular part, it was really nice. I mean, you have staining. Again, it's a little bit crushed. You have also necrosis. But this area,
the polydifferentiated area,
it's completely negative.
Okay.
It's completely negative.
This is what?
This was MLH1, I want to say, if I opened it correctly. I think so, yes. Yeah, because I click on this MLH1. I'm always seeing them.
PMS2.
Them in order. PMS2, again, even here, you can see this is more brown than this bit.
Yes.
So going here, nice.
Yeah. Well, you say nice, but there are some elements that are negative.
Yes, indeed.
I agree.
But also the whole washy-wash crash artifact and everything, an endoscopy biopsy. While here, you do have the stromal cells, but the poorly differentiated area is negative.
Okay.
And here the same.
6 and 2 are
and 6 and 2 are beautiful. This is MSH2. Unfortunately, it's flipped.
Okay, so that's...
So this was the poorly with here as well.
Yeah.
And I would say here a little bit crushed and ruptured as well.
Okay.
And the same for 6, I think.
And do you have...
No, on this one I do not have EDILA. I think this, I just said, that's proficient, that part is deficient, while the poorly differentiated, and we went on. But we did not perform EDILA on this one.
To tell you,
and it's a little bit more older case.
I have to tell you that gastric tumors are notorious for having a number of different, I would like to say different carcinomas.
Yes.
Some of them are diffuse, like ecadering negative, and the other ones are just tubular positive and And often you also find areas of dysplasia that are not really the same as the vesicarcinoma. So gastric.
Gastric, it is more tricky, and especially on PD-L1 interpretation. Oh, let's not go there. And the last one, because I know I don't want to. This is again a gastric. The gastric ones we really.
You like gastrics?
Well, carcinoma. Yeah, happy. I mean, again, not happy, but when we see this kind of invasive, everyone, it's okay. That's fine. When you don't need to wonder, is it high-grade dysplasia or not? This is MLH1.
Okay, this is lymphoma pathology, positive.
Okay, yes.
Yeah.
What do I have here? PMS2.
Probably similar.
Similar. Yeah. We were happy. Now MSH2.
Doesn't look very good.
No.
Oh,
Look at the stroma cells.
I would like to say negative, but there is a bit of staining.
But there is a bit. Here is more negative.
Yeah.
Yeah.
Probably negative.
This again is.
If I had a second test, I would probably. Let's have a look at the partner.
At the partner. Good. At the partner. Let me find the partner. MSH6. Look at the partner. Very washy-wash.
I wouldn't be very happy to report this.
And this one, you need to believe me now. We will put the report with Danidila on it, and it was MSH high.
Okay, so.
And I think with 7 out of 7.
So microsatellite instability. So you would report it.
So again, regarding you, how much can we accept, and how much is the threshold that okay we can, because we've seen something like this on a different one. But considering that the partner MSH2 was even more weak, almost negative. MSH6 is so weak as well, and you have some staining indeed.
But Corrado, why were you hesitating on the previous one? Because it was only a blush in the cytoplasmic.
You are right, but you like to see the partners in all these matters so that everything makes sense. Why was I hesitating?
Go up.
Where is it?
MSH2, this one.
Because,
this one was better.
Because look, overall, I can't really say, look how well these things stain.
More but if you look here, that's the problem here.
In this area. Right.
Yes, this is more.
Very nice internal controls here. And then you just have the blush.
Yes. And like this, considering this also with the internal control, the previous case when we started showing to you, when we have only one part that was negative and the stromal cells were completely positive and good internal control. Yeah, these are indeed the tricky case. And that case was MSS, microsatellite stable.
I don't know, Emilia, maybe if I didn't have a second test, I would have reported as deficient on the strength of these patients. Maybe.
I think this qualifies as deficient. But I think in do you have more cases? We only have 2 minutes.
No,
that's it. That's it. No.
That's why we
that's it. Wait, I think we also had this comment. It's amazing how much we can talk about. And this was a lot of proficient cases, but still so many things to observe. And I think that's also reflected in the variations of responses or comments that you got. But we also have a lot of comments here emphasizing what I think you've been saying several times, how important it is to make the report clear and make a statement. Is it proficient or is it deficient?
Or indeterminate, and I cannot tell you.
Or indeterminate, for sure.
Do something else. It's not always you need to make us, to be on one side or the other if you really are not comfortable with the test per se. It's always indeterminate. It's better to be on one side, but yeah.
No, I agree. As always in pathology, it's this or that that I don't know, kind of that type of answers we have. But
and Emilia, I wanted to say that with this endoscopic biopsy, it's important if you're not sure to say, I am not sure, we need more. Because that's the time, because then they start treating with chemoradiation. You have nothing to go about after that.
No, completely agree. But I think also what you said, to state that clearly, your conclusion in the report, and not having a wordy that might get misunderstood in the report by the clinician, so that your statement of deficient, proficient, or I don't know, or need a BRAF, or need genetic testing for Lynch syndrome should be clearly
highlighted. Yeah. We usually, Emilia, like write a report where there are all kinds of things in it, and then we have a summary. And the summary really is for the clinician. They say positive, negative, whatever it is.
And the report is for the colleagues.
Yeah.
No, I agree. So thank you so much. And thank you to all the participants for joining. I hope it was informative to you. I always find it very, very interesting. And I hope to see you next time.
So in August, we are having a circulation?
Yeah, Claudine 18.
Claudine 18 in August. Fantastic.
18.2.
18.2.
With
Very good.
gastric cancer, it will be very happy.
Okay. And then maybe we'll see you at the ECP.
Yes, in Vienna.
In Vienna. Very good. Thank you very much all for joining us. Thank you, Emilia. Thank you, Anne.